Good evening and welcome. On behalf of Mayo Clinic, in partnership with the University of Arizona College of Medicine, Tucson and Phoenix, we'd like to welcome you to our COVID-19 vaccine education and debunking of myths, a town hall for minority communities. My name is Dr. Alex Porter-Umphrey, and I'm an associate professor at Mayo Clinic. I serve as the outpatient medical director and the vice chair of diversity, equity, and inclusion. I have the honor of introducing you to some of my esteemed colleagues this evening, and you are definitely in for a treat. We've been collecting your questions since registration, and we'll have an opportunity to get them all addressed. If you have not pre-submitted your questions, please use the Q&A down at the bottom of your screen, or feel free to submit in the chat as well. So with that, I'd like to first introduce you to my friend and colleague, Dr. Elisa Shapatel. Not only is Dr. Shapatel an associate professor of surgery, but she has trained in surgical critical care and currently serves as the hospital medical director for Mayo Clinic. Dr. Shapatel is well known as the calming voice amidst the storm, and she really has truly been the force behind our hospital incident command center and leader here at Mayo Clinic in Arizona. So Dr. Shapatel, welcome, and I'd like for you to share with us what you've learned about the risk of COVID-19 infection in minority populations.
Wonderful. It is my pleasure to be here, especially amongst this audience and my esteemed colleagues. I am going to spend a little bit of time just covering the data regarding COVID-19 infection for the minority population in the United States, and then begin the argument to support minority vaccination and stress your part in this war on COVID. So just some basic census information to level set. There are 60.1% non-Hispanic whites in the population in the United States. African Americans make up 13.4%, Hispanics and Latinos 18.5%. However, minority populations, particularly African Americans, are dying at a disproportionately high rate from COVID disease. In addition, we're dying at younger ages than white Americans. I recently saw a webinar where Dr. Ebony Hilton said that we are breaking all of the wrong records for Black and brown people. Black people are dying at coronavirus at an alarming rate that is 2.5 to 3 times higher than other groups. The most recent data that we have from January 5th showed that 55,580 African Americans are dead from COVID in America. That's one Black person for every 735 in America dead. There are 60,298 Latinos dead of this disease, and Indigenous Americans have a mortality rate that's 2.2 times higher than Caucasian Americans. Why are we dying? There was a recent JAMA article that challenged the notion that Blacks and Hispanics are inherently more susceptible to COVID disease. So this supports the assertion that existing structural determinants, not true biology, that remain pervasive in America, in our Black and Hispanic communities, result in a higher COVID-19 related mortality. So we know about these. There's inequality in housing, access to care, differences in employment opportunities. However, there are some implicit biases in the way we are diagnosing COVID-19, so in testing access, admission rates to the hospitals, and access to treatment. There has been some recent data on monoclonal antibody distribution that shows there's a wide gap in those who are receiving this clinically proven treatment. So we know that the federal government has given $40 million to help develop networks for this, but the fact is they currently do not exist. This is a state of emergency. The siren should be blaring. We should be calling for equity at this time whenever we can, but particularly with vaccine distribution. So prevention is the strongest tool that we have now in this battle. So we as advocates of minority and American health need to be a voice for our patients right now. So this is why we're here. We need to promote minority vaccination. So how do minorities approach vaccines in the United States? Well, according to the Office of Minority Health, minority vaccination rates are lower for adults than non-Hispanic whites. We know that African Americans are less likely to receive vaccines for the flu, for pneumonia, for HPV already in the United States. And when they surveyed, so the Pew Research Center surveyed the population, just 42% of African Americans were willing to receive the vaccine. They indicated that they were willing. And last month, the NAACP released a report about vaccine hesitancy, and I think some of my other colleagues will be talking about that. Just 14% of African Americans surveyed said that they trusted vaccine safety, and so that's why we're here. So why should white Americans be concerned? Well, without minority participation in vaccines, we may not have enough people vaccinated to reach herd immunity in the United States. So we need approximately 70% of people in the United States to take the vaccine to reach herd immunity. And another one of my colleagues will be talking about that. But we talked about Caucasians making up 60% of the population. And a recent study showed that only 68% of Caucasians would be willing to get the vaccine. So that will only get us to 42% of people vaccinated in the United States. So we need African Americans, Latinos, everyone to participate in vaccination if we are going to win this battle for COVID. So I'll just end this by saying to you, my colleagues, protect yourself, get vaccinated, be the example, and then teach everyone you know about vaccines. Thank you.
Thank you so much, Dr. Chapatel. When we start to ask ourselves the question of why certain groups are suffering disproportionately, we can't ignore some of the associated comorbidities, some of those other diseases that Black and Brown communities often suffer at much higher rates. And so with that, I'd like to introduce my colleague, Dr. Richard White at Mayo Clinic in Florida. Dr. White is an assistant professor of internal medicine and pediatrics, and he has a research interest in diabetes treatment prevention, particularly in racial and ethnic minority populations. And Dr. White is going to share his thoughts on the importance of ongoing chronic disease management amidst the pandemic. And he's also going to tell us more about effective risk communication and supportive vaccine uptake among communities of color. Thank you for being here, Dr. White.
Thank you so much, Dr. Porter-Humphrey, and good evening or good afternoon. It's evening where we're located to everyone. Just an honor and privilege to have been invited to participate with you guys in this very important discussion about helping people to really be able to understand the importance of vaccine. So as Dr. Chapatel mentioned, or I'm sorry, Dr. Porter-Humphrey mentioned, I'm a primary care provider on the Florida campus and have the great privilege of taking care of adults and children. But some of the other hats that I wear and titles that I wear that are actually more important to me are that of son, are that of father, are that of husband, are that of brother. And I wanted to try to frame some of my comments and questions tonight from that perspective. Many of you, if you're like me, it didn't take long for us to realize that this infection was a very serious infection. And some of the questions that you probably asked that I was asking myself as an individual who has been diagnosed with asthma since I was a child, what is my individual risk? And then shortly after that, beginning to think about my family members and those that are closest to me and thinking about, well, what might be their risk? My parents are in their 70s, and we have, like many communities of color, have some chronic illnesses that run through our family. So as Dr. Chapatel was mentioning about some of the disturbing statistics, I think more than anything, COVID-19 has really served as a magnifying glass and highlighting, a lot of the known disparities and health inequities that unfortunately have persisted in our country for far too long. We've seen, particularly among communities of color, higher rates of hospitalization, higher rates of mortality from the infection. And something that's certainly been concerning to me and concerning to family members and to the communities that we have the privilege of taking care of. If you look at the hospitalization data for particularly, One of the things that explains some of that is individuals that are older age, individuals that have one or more chronic conditions. And when we talk about this term chronic conditions, you think about things like heart disease, like high blood pressure, like diabetes, respiratory condition, cancer. These conditions that are putting people at higher risk for COVID-related hospitalization and COVID-related mortality. And unfortunately, we see those in higher rates among our communities of color. And as a result of that, it's partially explained some of the disturbing and concerning stats that Dr. Chapotal mentioned. So as a primary care provider, I know that it's really important for us to continue to treat chronic illness, particularly I see a lot of patients with diabetes and high blood pressure. And unfortunately, during this pandemic, there have been a lot of care delays. I know that in our hospital in our clinic, we've experienced particularly at the beginning of the pandemic, a lot of delays in care. And as you can imagine, people are not being able to see their providers on a regular basis like they were seeing prior to the beginning of the pandemic. A lot of my patients that are now coming back into the clinic where it's safe to do so and they feel comfortable coming back for in-person visits, unfortunately are reporting that they've experienced a significant amount of weight gain during the pandemic. Their alcohol intake has increased. And as you can imagine, a lot of these things don't bode well for an individual who's trying to work to control their diabetes, who's trying to control their blood pressure. So unfortunately, I've seen a lot of my patients come in with worse control for their chronic conditions. And that just serves to even increase an individual's risk for poor outcomes from COVID. Unfortunately, a lot of our communities of color haven't had the fortune of being able to participate in telehealth visits and things along those lines. So there have been concerns about those delays as well. Just to shift gears and to talk about the importance of communicating well with your providers. One of the other hats I wear is a health communication and health literacy researcher, and we know that healthcare providers are unfortunately guilty at times of using terminology that's can leave a patient confused and not understanding exactly all the information that they need to understand as far as managing their illness. There's health literacy is a significant issue among many of our communities where individuals may have a difficult time being able to understand the health-related terms. So when I'm educating residents and I'm working with other providers, I always encourage and challenge them to be mindful about communicating in a way that their patients can really understand. But I think there's some important things that I'd like to leave with you guys as well, as patients and just as individuals in the community. When you're interacting with your healthcare team, it's really important to make sure that you understand and advocate for yourself and for your family members, particularly to ensure that the information that you're receiving from your healthcare team is information that you understand, information that you can take and that you can use to make adequate healthcare decisions. So I'd like to leave you guys with just 3 questions that I want to encourage and challenge you guys to adopt as you're communicating with your healthcare team around the vaccine and the questions that you have. The first is always ask, what is my main problem? Number 2 is, what do I need to do? And number 3 is, why is it important that I do that? And I look forward to your guys' questions.
Thank you so much, Dr. White. For those of you who have joined us a bit late, welcome. My name is Dr. Alex Porter-Umphrey. I have the privilege of being the moderator of tonight's town hall. We're here really to get questions answered, to demystify the COVID-19 vaccine. And we're paying particular attention tonight to what vaccination means for minority communities. That means that everyone should be interested. You don't have to just be fall within the category of being from a community of color to participate tonight. We really want to stress the importance of everybody needing to have some interest and understanding about what's happening, not only with the vaccine itself, but also to really demystify some of the misinformation. And so please keep your questions coming through the Q&A and through the chat. And next, I would like to introduce our next panelist, Dr. Francisco Moreno. We can't underestimate the impact of the stress that has been associated with this pandemic. And along with the stress, we've had to navigate, or maybe what's causing the stress is having to navigate all of the information that's come at us from different directions. And so Dr. Moreno is a professor of psychiatry at the University of Arizona, and he's the associate vice president at the University of Arizona Health Science Office of Equity, Diversity, and Inclusion. And his work is really focused on increasing diversity of the health professions workforce to increase the cultural proficiency and community congruence of health services and research to try to address Arizona's health priorities and decrease health disparities. So, Dr. Moreno, please tell us more about COVID and vaccination information mistrust as a global phenomenon in the communities that are at highest risk to look out for some of this misinformation.
Absolutely. Thank you very much, Dr. Porter, for the kind introduction, and thanks for the opportunity to be here with all of you. I have the pleasure of collaborating with a very interesting project called the Community Engagement Alliance Seal Against COVID-19 Disparities, and that's a collaboration with the Mayo Clinic, University of Arizona, Arizona State University, and Northern Arizona University as well. This is funded by the National Institutes of Health with the plan of really improving the information that we are sharing with providers and also with community members. So very excited to be here because as we had shared during the introduction, there is a whole lot of misinformation and disinformation. Most of it is well-intended, and people have beliefs about health and about remedies and concepts of disease that make sense to us, and we share it with others. Many times the traditional beliefs and the interventions that we have been very wisely created over millennia for people and just generations for some of our cultures. However, we're really facing a couple of new challenges. One of them is the challenge of a new virus that we know very little about. And the other one is now we're dealing with this technological explosion in which we have so much information that may not be well curated, that comes to our phones or whatever, television, and we don't really know a whole lot what to do with it. When you ask people around the world, do they trust the information that they get? Do they believe in COVID? Do they believe in the vaccine? Many will tell you no. And the people that may say no are folks sometimes that do not trust the government or do not trust the institutions that do the research. But even here in the United States, that's also reflected in who will tell you that they will get the vaccine. When you ask around, there's a couple of research that have been published recently. It shows that a lot of people are not thinking of getting the vaccine. It's worse, the proportion of people that says, no, I'm not gonna get it, or I'm not sure that I will get it, is worse in women, is worse in people of low socioeconomic status. It is also low in people that have low literacy levels and less educational achievement. It's also lower in people that have larger households, and is worse in the South than it is in the Midwest or in the Northeast. And it's worse for people that don't get their flu shots. And so when you look at the racial and ethnic groups, again, African American and Latinx individuals are a lot less likely to endorse a plan to get it. In addition to that, now we know that there's some challenges in the distribution of the vaccine and the access to the vaccine. And we're also seeing, similar to the information that was shared about the access to the monoclonal antibodies, the antibodies that famous people have gotten, the same thing is happening with the vaccine. In terms of not everybody having access to the electronic options that are given to us to set up an appointment at the sites that have been selected for people to receive the vaccine. So part of our work then has to be to work with folks so that we can demystify and clarify a lot of the questions that folks have. Very glad that you're all here joining a group of experts. The colleagues that are here with us are people that can help provide reassuring information. Working in psychiatry and behavioral health, we've seen a large increase in stress in people that normally may not be having a lot of anxiety associated to the stressful lives that they have. But COVID has really tilted a lot of people over the edge in terms of now having a lot of behavioral problems, anxiety problems, substance and alcohol abuse problems, relational issues, and other concerns that affect their own ability to remain healthy and participate in sort of wellness and other social protection activities that people have. So I'm going to stop there with my comments, and I look forward to seeing what kind of questions people have. Thank you.
Thank you so much, Dr. Moreno. Next, I'd like to introduce Dr. Ivan Porter. Dr. Porter is an assistant professor of medicine and vice chair of the Division of Nephrology and Hypertension at Mayo Clinic in Florida. He's the chair of Mayo Clinic Florida's Community Engagement Committee. He's the medical director for the Office of Access Management and serves in leadership of the Internal Medicine Residency Program. Before we hear from Dr. Porter, we're going to watch a quick video, and then I'll turn it over to Dr. Porter to share his thoughts.
I think the population in general has fears about getting administered a brand new COVID vaccination and what could be, but I just want to stress that that level of normal that everybody wants to have will not be attained if we don't have broad acceptance of this vaccination and what that can bring to the population and population health in general.
Dr. Porter, please tell us more about who should get vaccinated, what herd immunity is, and the individual responsibility we have to protect those around us. Please.
No, thank you very much. It's my pleasure to be here. You know, speaking of being the example, I mean, I've shared that video with a lot of my family and had it sent out to a lot of friends, and hopefully that's made an impact. This is an important priority, and that's why I take the time to do it. Just so you know, that was the first dose of the vaccine I received. I give blood regularly. I happened to give blood 13 days later, and I had positive antibodies. You know, when you give blood, they test for antibodies. Quick turnaround. So that was certainly good news. And the only other plug I'll give is, you know, my wife is an OBGYN. She's Blindian. She's half Black, half Indian, for those taking notes, just like your vice president. She was a member of the Moderna trial. Broad adoption of this in all populations, including minority populations, is so important. And that's why it's so important for us to talk about this together. You know, I spend a lot of time in my role in community engagement. We've coordinated numerous community testing events for COVID. Annually, I speak the importance of annual vaccinations. I work directly with COVID patients with kidney disease as well, my dialysis population, my hospital population as well. I'm used to spending a lot of time debunking myths. I'm used to saying, no, you did not, in fact, get the flu from your inactivated flu virus. No, you are not encouraging sexual activity in your child by preventing cancer by a known agent, by getting the HPV vaccination. But it's difficult. It's difficult when things are new. It's difficult when we question safety. It's difficult when the rules seem to change or the guidelines change, and it's different from state to state or area to area. While the Committee for Immunization Practices may have a recommended group that gets vaccinated, the dynamics of your state or the availability of a vaccine may make that different, or prioritizing other populations or age or medical issues. It may make it more difficult. The fact remains that broad adoption is the only way that we can truly make a dent in what has been lost over the past year. You know, anybody that can get this vaccination should. Everybody that can should. There are a number of reasons that you hear that people don't. The lack of trust. That's the purpose of tonight, to try to talk about that and educate. It is not my role to force or insult anyone here or in any place to tell them why they have to get a vaccine. It's about education. It's about fighting that mistrust the way we would have to do with anything that lacked trust. We'd have to build that trust first. You know, the safety of this vaccination, as far as the time course, we have to know that this data has been being collected for years. This is decades of work. Based on previous endemics, other coronaviruses like the MERS virus, all of that work is what allowed us to be able to come up with a vaccine so fast that's effective, very effective. We have to concentrate on the data that we have. It is okay to be afraid about what we don't know, but that doesn't mean we can ignore the data that's in front of us that is what we know. Another thing that we know that should be important to minority populations is that the lead researcher here, the scientific lead of the Viral Research Center at the NIH, is an African-American woman. Her boss is a white male, but his Black wife and their mixed race child participated in the Moderna trial. It speaks to the importance of minority recruitment in all of the trials that we do and all the scientific trials that we have. To speak to herd immunity, I would just say that it's almost irresponsible to talk about it. We don't know yet if community spread occurs despite vaccinations. Like, we certainly have the data that we have, but community transmission is likely still possible even after a vaccine. We know that in populations that have a high prevalence, so that means that a lot of people have already gotten coronavirus, we still see effective community spread in those populations. All those would argue against some idea that we can just wait for everyone else to either get the vaccine or get COVID and we'll all be fine. More importantly, some people can't get vaccinated, right? There are some people that don't have the immune system or can't develop the immune response. We have a responsibility to protect those people that we care about. It isn't just about me in Jacksonville, Florida. I mean, I'm allowed to travel freely from state to state, even country to country at certain times, right? So we put everyone at risk. We have an individual responsibility to protect the people that we care that are around, that care about, that are around us. As with anything, it's about partnership. It's about education. I just challenge us to focus on the things that we know and not ignore that information as we learn about the things that we don't know and the information comes in. I'll be happy to discuss anything as we move forward, and I appreciate the opportunity.
Thank you so much, Dr. Porter. And we often talk about that desire to be in the room when it happens. And we have the privilege of being joined by Dr. Benacloche, an infectious disease specialist who was part of the FDA advisory committee that recommended the emergency use authorization of the Pfizer COVID-19 vaccine. Dr. Benacloche is a professor of medicine and an infectious diseases physician with an expertise in immunology and immunocompromised patients. So Dr. Benacloche, please tell us more about the transparency of the vaccine evaluation process, distinction between emergency use authorization and approval, and then finally, efficacy and toxicity of the authorized mRNA vaccines.
Well, thank you for having me and giving me the opportunity to talk about these things. So I think that the process of authorization of the vaccine has been extremely transparent. So the FDA announced the way back in October what were the criteria that any candidate vaccine had to fulfill to receive the authorization, and that was public. All the guidance of the FDA has been public and it's open to comment. If you go to the FDA website, you can find a way to send your comments about anything that they say. Everything is available. All the documentation that was presented to the committee for authorization of the Pfizer vaccine, of the Moderna vaccine, all the data there. The data on the vaccines, the preclinical studies, the phase 1 studies, the large phase 2-3 studies that have shown the efficacy and toxicity, everything is out there. The distribution of population that participated in the trials, it is available. You can see it. It's very important, since we are talking about minorities, to know that 25% of the participants in the trials of the Pfizer and the Moderna vaccine identify themselves as Hispanic or Latino, and 9.5% as African American or Black. And so they are not as outside of the actual distribution of the population. Minorities have been part of the evaluation process, and we know that vaccines work just as well in minority populations as in whites. So it's very important to be aware of that. There has been nothing has been under the table in the authorization of these vaccines. Then important, the distinction between emergent use authorization and final approval of a vaccine. So the emergent use authorization means that based on everything we know up to this point, the benefit of the vaccine outweighs the risk. And that is what the opinion of the of the advisory committees was, and that was what the opinion of the A was, and that is why these vaccines can be used. This is, if you will, temporary. At some point, the vaccine will receive final approval when there are more data. At this point, we have 4 months worth of data, and based on what we know from those 4 months, the efficacy and the benefits clearly outweigh any risks associated with that. And that is in good measure, that is for two reasons. One, the benefit is extraordinary. So the 94, 95% efficacy is something very seldom achieved with a vaccine. And it was an unexpected surprise that, that these vaccines were so extremely effective across the board. Um, and then the issue of the toxicity, and I cannot emphasize this enough, um, the vaccines are, they elicit a very strong immune response. So a lot of people have reactions to the vaccines. There's no way in which you can whitewash that fact. 70% of people will have general side effects after the second dose. That's a lot of people. So you are more likely to feel something after the second dose than to not feel anything. And that it differs. In most of our vaccines, we are able to say, well, yeah, there's a chance that you may develop a fever or feel unwell the day after you get the shot, but more likely than not, 90% chance you will not feel anything. And this is not the case with these vaccines. With these vaccines, more likely than not, you are going to have side effects after the second shot. More frequently if you are younger than 55. But the toxicity, those side effects are not a big deal. So yeah, you may feel very tired, you may have a headache, you may be unable to function at work for one day, but those are effects that usually last for 24 hours. They typically resolve within 3 days, and they have nothing compared with even a mild case of COVID. So there is really no contest. The safety of the vaccines, as far as we know, is excellent. And a common objection that is presented about these vaccines is, if you only have 4 months of data, how can you know that they are safe, that they are truly safe? And the answer is twofold. Number one, we know that they are safe for 4 months. We know that. But based on what we know about vaccines, the real toxicity of vaccines almost always appears in the first 6 weeks after vaccination. So when we have 4 months, 4 months seems short when you are thinking about really long-term toxicity, but that doesn't seem to happen with vaccines. It hasn't happened historically with vaccines. And the same way that science builds on previous knowledge, based on what we know, we think that it's appropriate to say that these vaccines seem safe. And that, for that reason, based on the evidence that we have as of today, there's no question that the potential benefit of these vaccines far outweighs the risk.
Thank you so much, Dr. Benacloce. We're going to open it up for question and answer. And so you all have been doing a great job sending your questions through the Q&A. Please keep them coming, and also through the chat. And so, Dr. Benacloce, I'm going to come back to you to tell us a little bit more about what we know about the long-term efficacy of COVID vaccine, and whether or not this is going to be sort of like the flu shot, where it's recommended that a yearly booster is needed. So please tell us more about the long-term efficacy.
Well, as I said, because we only have 4 months worth of data, we don't have a lot of data about long-term efficacy. So we have been measuring the duration of the immune response generated by the vaccine, and we can say that you definitely get 4 months worth of protection with these vaccines. We are measuring the protection that people get with actual COVID infection. And we say that, yeah, that probably you are protected for at least 3 or 4 months. The longer we wait, the more we will know. Uh, it's important to know that the immune response, at least the way we can measure it in the lab, the immune response generated by the vaccines seems to be as strong or stronger than the immune response generated by the actual infection. And so what we presume is that the vaccine is going to be good for a few months. Now, it's early to say how long that is going to be. In addition, it's important the analogy that you bring up. So the flu vaccine is something that it's a virus that mutates, and it's not like we need a booster, it's that we need a new shot every year. The predictions about what is going to happen with COVID are very varied. It's possible that the virus is going to stay in the community, and that for years to come, there's going to be a respiratory virus that can be extremely severe, and that is going to need annual vaccinations. I don't think that is an unlikely scenario, but at this point, we really don't know.
Thank you. Dr. Porter, this next question is for you and really is about the difference between Moderna and Pfizer. And so the question is, what do you do now that your family members have seen the video that you shared with them? What do you do when a patient or family member or friend says, I only want the one that you got, Dr. Porter, referring to whatever brand you received? How does somebody respond to that?
Yeah, my best response would likely be get the one that's available to you. And I might even explain the differences, in creation. I mean, if we think about a science project that we gave our kids of how to protect eggs and then throw them off a building, we can think of that as how the differences between how these vaccines are being made. We got to find different ways to protect this mRNA, and that kind of can explain some of the differences in storage, and that those differences in storage explain the differences in where they can go and when they can be delivered, and then how practical it is to get it to the population thereafter. So some places just may not be eligible to have a Pfizer vaccine because they don't have the infrastructure to do so. And in those cases, you should get the Moderna. And when there's another one available and we know that that's safe and we trust the data, you should get that one if that one's available. That's the best answer that I have. Honestly, I can say that, depending on the time, I may have gotten a different vaccination, and I can speak to my personal experience with the vaccine, and hopefully that will relate. But again, everyone's different. I mean, we just heard the comments about the differences in reactions. The younger people that may have had worse reactions after the second vaccine. I had a little bit of arm pain. That was it. I knew that I had antibodies. I told you about the giving blood, but that didn't mean I had a less robust response. It didn't mean that I'm going to be less protected. We're all a little bit different. So the best answer, whichever one's available and offered to you that you were able to make that appointment for, that you sat on the phone, go get that one. That's the right one for you.
Thank you so much. Dr. Moreno, this question is for you about how to provide reassurance to people who might be concerned about the impact of the vaccine. And so the question specifically says, I have family that are concerned about the likelihood of dying from the COVID vaccine. How would you reassure someone with that concern?
People have a lot of anxiety about what they anticipate may happen to them. Sometimes it's rational, sometimes it really becomes irrational. And so what's important here is, rather than a blanket statement of this is how we should do this, is to get to the person, validate their concerns. I hear you, I know you're worried. Tell me, what is the specific concern that you have? And people will sometimes tell you, well, I heard this is not well tested yet. They rushed it through, or the government made it, or they're giving us a different one. And then you have an opportunity to address specific concerns that people have. We often have distortions in our reality that we can orient people to a better understanding of things. So we give them, we are honest, and we tell people, like Dr. Porter said, it hurts. And Dr. Benacloche said, this is what happens. So we have to be transparent with people. We have to talk stuff, but we always have to start by listening, understanding, and trying to correct the distortions that people may be having. Because people don't worry about dying just because they worry about dying. There's something that drives them to that.
Thank you. Dr. White, this next question is for you, and we're going to jump right in about some of the potential misinformation that has been put out there about the vaccine. And so the question is related to infertility and vaccination. And so specifically, I have family members who are concerned about infertility if they take the COVID vaccine. Is there any research or information tackling this concern?
Yeah, so this really is misinformation. I know of no data to support the concern that if an individual receives a vaccine, that'll put them at risk for infertility. And you know, I've been getting questions. You know, as a pediatrician, I actually saw a family just this morning where the mom was considering pregnancy, and she was wondering whether she needed to delay pregnancy in order to receive the vaccine, and there's really no specific recommendation for that. You know, so I think that it's important to, when you're hearing information out in the community, I think it's important to understand that there's a lot of misinformation that's circulating in the community, and to ensure that you're getting your information from trusted sources. You know, I send a lot of my family members to our Mayo Clinic website where we've got information about the vaccine. To the CDC is a lot of the information is available. So I think it's just important to really make sure that information that you're hearing in the community is from a trusted source, and that it's been verified by individuals that you know and trust. So yeah, that's really really just flat out just misinformation.
Thank you. And Dr. Chapatel, I want to turn to you next about the best way to handle and help educate and empower our colleagues. And so the question is whether or not we have any suggestions on how to handle when colleagues start to talk about people who don't trust the vaccine yet. And in medicine, sometimes we tend to label people quickly and call them non-compliant or uneducated. How do we prevent perpetuating these bad patient stereotypes or unconscious bias against minority patients or minority colleagues while still promoting vaccination?
And I think this goes back to my original statement about being the example. I think it is on all of us to be an example. So we have to educate ourselves. And I think the first step is that's why everyone is here today. But there are a lot of, I think Dr. Marino said, there are a lot of issues that surround people not getting vaccines. And there's fear that may be involved. And so it's not a good thing to perpetuate these stereotypes. It's on us to educate folks. And so that's what I would say.
Thank you so much. Dr. Bonacloci, my question is about mRNA. So can you help us understand a little bit more about mRNA and whether or not the vaccine will change our DNA by receiving it?
Yes, that's a good question, and it's not a question that is easy to answer unless you have some basic understanding of cellular biology and the immune system. Essentially, the mRNA is the blueprint for making proteins. So every protein that is made by any organism, the instructions to make that protein are in the form of mRNA or messenger RNA. So mRNA for the spike protein, which is the mRNA that is present in both the Pfizer and the Moderna vaccine, is simply a set of instructions that allow the cells in which that vaccine gets into. It will allow those cells to make copies of the spike protein of the virus. The mRNA is degraded without ever getting into the nucleus of the cell where there is the DNA. So if that is the concern, it doesn't happen. The mRNA doesn't get into the nucleus. It cannot possibly get into the nucleus. It cannot change your DNA. So that's number one. Number two, because of the way the immune system works, every protein that is synthesized inside the cells is presented by a variety of mechanisms to the immune system of that organism. And is presented to see, for the immune system to decide, is this my own protein or is this a foreign protein that may be a threat? And if it is identified as a foreign protein that may be a threat, you generate an immune response against it. So the very nice thing about an mRNA vaccine is because it creates the whole protein, and then the organism develops an immune response against the whole protein by all the mechanisms that the immune system has to develop that reaction, it creates a very broad-based immune response against the virus. So it is possible that the virus at some point will evade that response if there are a huge number of mutations on the spike protein, but it should be harder than for many other vaccines to develop resistance to.
Thank you. And Dr. White, with your background as a pediatrician and having a broad understanding of medicine, do we know what impact vaccination has on young adults or children?
So there's a wealth of data, wealth of information that vaccines, as pediatricians, we often tongue in cheek say that, the vaccines, produce adults. So vaccines are very protective. There's a wealth of communicable diseases, meaning that these diseases can be spread from one person to another, that we know that vaccines prevent kids from getting those infections. As far as the COVID vaccine is concerned, the two vaccines that are on the market now, Moderna and Pfizer, are only indicated for individuals 16 and older for the Pfizer vaccine and 18 and older for Moderna. So we don't have information on vaccine efficacy in children younger, and they're actually not indicated for children younger than those ages. I do know that we are starting, that Pfizer and Moderna have started some vaccine trials in younger children, I believe as young as age 12. But it's still going to be a while before we have vaccines that are available for those younger age groups. And for the younger children, infants and younger toddlers and younger children, time will tell whether eventually. My hope is that we'll eventually have vaccines available for those children age groups as well. We know that vaccines are safe in as young as infants. We give vaccine as early as birth. You get the hepatitis B vaccine on the day that you're born, within a few days of birth, and we give vaccines all the way through childhood. So we know the vaccines are safe in children, but we don't yet have a vaccine for COVID that's available for that age group.
Thank you. Dr. Moreno, this next question is about domestic violence. And there's been report of increased rates of domestic violence within the pandemic. And so this question is in regards to your thoughts about what might be behind that. Do you think there's some relationship to vaccine, people arguing about whether or not to get the vaccine? And so please share your perspective on domestic violence in the setting of this pandemic.
Yeah, thank you. That is a very important question. There's a lot of reasons that had facilitated an increase in domestic violence. We spent a lot more time together at home. We brought a lot more stress from the kids' school in the house. So there's been a lot more of domestic violence towards the children as well. A lot more time interacting with each other, stress from financial issues, and also many times disagreement as to how we perceive the need to be taking precautions. And many people in the family may have very different attitudes about what they do with this. So the one connection I would make with the pandemic precautions and information and attitudes towards COVID would be that sometimes there's differences that also lead to tension among people. But make no mistake about it, when people are stressed, when people are anxious or depressed, when people are drinking more or using more drugs than usual, which has been happening, and more painkillers as well, this is going to be resulting in a lot more difficult interactions. We have to be working proactively to make sure that we are at our best, that we are as generous as we can be, that we really prioritize the attitude of supportive parenting and partnering with the members of our family to avoid increases in tension that may lead to domestic violence and other forms of abuse.
Thank you so much. This next question is for Dr. Porter as a nephrologist. The question has to do with side effects and whether side effects are different for those patients with underlying issues, whether it be high blood pressure or prior cancer treatments, for example. So are the side effects different if you're over age 60 with other medical comorbidities?
There have not been reported differences in side effects based off of medical condition. Only what you was briefly mentioned about perhaps more severe side effects in younger individuals after the second dose. But again, I told you that's not 100% either. But to my knowledge, there are not differences in side effects to expect if you have diabetes or if you have hypertension or if you've had a kidney transplant. Really, the most important thing to think about when you're immunocompromised or when your immune system is affected when you are a transplant patient because you take medications that affect your immune system is the timing. So a discussion with your provider is what's important at that time. We know that at the time of transplant, we would like to, if someone's planned for a transplant, we either want to get them vaccinated ahead of time or there's a time period to wait to get it done afterwards, simply because the immune system can't create the response needed by the vaccination that's administered. So certainly there are circumstances that require discussion, but the condition itself does not prevent you from being able to get it, and you should not be worried about differences in what happens based off of the condition. I believe I saw a previous question about HIV, same way. Those that are affected with HIV, while there haven't been large-scale tests, HIV patients were included in these trials, and there were not adverse effects reported, adverse events reported. So even in that case, yes, we would want to promote vaccination in those groups as well.
Thank you. Dr. Shapatel, this question goes back to, again, the discussion about Moderna or Pfizer. So if you start out with vaccine number 1 with Pfizer, and then Moderna becomes available to you, how do you handle that? Should you switch and do the Moderna vaccine for your second shot, or should you stick with the first one?
Thank you. It is not recommended to switch vaccines in the middle. You need to stick with the same vaccine that you got. Dr. Bonaclocha could probably tell you there's probably no data that will say that that is safe or that you'll get the immunity. They're made completely, they both affect mRNA, those two vaccines, but I think there's a question on the Johnson & Johnson vaccine that's coming out, which has a different mechanism of action as well. So it is not recommended to switch vaccines mid-vaccination.
Yeah, if I may, the CDC has made public guidance regarding that, and they state that every effort should be done to get the second dose that is from the vaccine that you got the first dose from. However, in that same recommendation, they say if for whatever reason it's impossible to get the second dose from the same one, you can get a second dose from either of the two, and you don't need to restart the series, and you don't need to get more than 2 shots, and after the 2 shots you are done. They have different things. They have different ways in which the RNA gets into the cells in the two vaccines, but they are essentially the same vaccine, and that is the reason the efficacy is so close. And so it should not be done. You shouldn't do it, but say that for unforeseen circumstances, your only options are to live with one single shot of one vaccine or to get the second shot from the other, go and get the second shot from the other one.
Thank you, Dr. Bonaclocha. And on that same thread or same train of thought, if 1 year you happen to get the Pfizer first and second vaccines, and then next year you get Moderna, do you see any difference between those two?
I don't see any difference between those two, but here we are really getting into the speculative thing. I don't know where we are going to be a year from now. We don't know how long really, because we don't have enough follow-up. Keep in mind that these vaccines started development in March or April, so we don't have enough follow-up to answer that question properly. And it may be that a different vaccine will be a better idea afterwards. So I think that is to be seen. I don't anticipate that just because you received the Pfizer vaccine in 2021, then you are stuck with Pfizer for the rest of your life. That doesn't quite make sense.
Right, thank you. And I'm going to squeeze one more question in on the same train of thought. What is the longest period of time that would be acceptable between shot 1 and shot 2?
there's no time limit. So the recommendation is to get the vaccines as the companies recommend them, because simply because that is what we have studied. So we know that the efficacy of the vaccine is so and so when it's given in this particular way. We don't know what the efficacy is or how long it may last if it's given in any other way. Um, but if you have to postpone the second dose for whatever reason, um, there's no time where you need to restart the series. Just get the second dose and you are done. That is the CDC recommendation.
Very good. Thank you so much. Let's turn it now to Dr. Shapatel. One of the reasons why we're having this dialogue, this town hall tonight, is to actively try to prevent COVID-19 infection. And as a critical care specialist, can you tell us a little bit more about what we see in our ICUs in our hospitals for people that are infected by COVID-19 and why we're working so hard to get information out there about being vaccinated?
So we are seeing people dying from disease. The percentage of people who get infected that die from disease is relatively low. So it depends. It's about 1 to 2% depending on where you are in the United States. But people are dying of respiratory failure and multi-system organ disease. So their kidney shut down, their body shuts down due to sepsis. So overwhelming infection. We are seeing that we have a significant number of patients who are sick at the same time. And so what that does is it stresses the system, stresses resources. We here in Arizona have a significant number of patients occupying our ICU beds. So my latest count, we were at about 90% occupancy in our intensive care units. And so we see that number is plateauing, but it's significant and it hasn't come down yet.
Thank you. Dr. White, are you making any kinds of recommendations to folks prior to getting their vaccine in regards to pre-medications? Maybe some people have talked about pre-medication with acetaminophen or Tylenol or diphenhydramine, also known as Benadryl. The question is about pre-medication prior to vaccination.
So that's a good question. So I'm not making a specific recommendation for pre-medicating, but as Dr. Benacloci mentioned earlier, more than half of the individuals that receive particularly the second dose of the vaccine are experiencing some mild symptoms. And, after I got my second dose, I had that experience with some mild muscle pain, a little bit of some chills, a little headache. Thankfully, it only lasted for about 8 hours. I personally, because I heard, some colleagues that had some similar experiences. So I prepped and I did take some anti-inflammatory medicine before getting my shot. I haven't been making that as a broad recommendation to my patients, but I have been, speaking with them openly and transparently about potential mild side effects from the vaccine. And as was mentioned earlier, I'd certainly make it clear to people that, the mild symptoms that are very transient, so they're short-lived, they don't last for more than a day or two, is way better than having the actual infection. So I encourage people to let them know that they're welcome to take some Tylenol prior to their vaccination or thereafter if they do develop some mild symptoms, but make sure to remind people that those symptoms are very short-lived.
Thank you. Dr. Benacloci, the question is about safety of vaccine in a couple of unique circumstances. If a patient has a prior history of transplant, if a patient has a prior history of cancer, is it safe to get the vaccine?
Yes, in the case of cancer, we know that it's safe for sure. In the case of transplant, there is a concern, hypothetical concern, that some vaccines that create a very strong immune response can make an immune response so strong that there's the potential for some degree of activity against the transplant, against the graft. So that is completely theoretical. It's not based on any data because transplant recipients were actually excluded from the trials. So we don't know about transplant recipients. We do know that because in transplant recipients, there is ongoing manipulation of the immune system, and it's very important that it's kept exactly right, not too active, not too weak. I think that any intervention in that setting, one has to be cautious, and that is the general case for vaccinations after transplant. But the CDC in their guidance say go ahead and get the vaccine until we collect more data. The urgent data that are trying to collect right now is on pregnant women and children.
That was my next question, actually. We've had a few questions about for women that are pregnant, seeking fertility treatment, or breastfeeding, if we have safety data for those circumstances.
We don't because they were excluded from the trials. So we know that women who were participating in the trials and got pregnant during the trial because that they were not forced to use contraception. There were no side effects and there was no detectable toxicity. And we do know that COVID can be particularly severe in pregnant women, and it may increase the likelihood of toxicity in the fetus or the newborn. So if I had to choose with the very limited information, my personal opinion, which is not the opinion of anybody else, is that the benefit of the potential benefit of the vaccine probably outweighs the potential risk even in pregnant women. But the data are very limited. Those women were not included in the trial. Other infectious diseases experts give exactly the opposite recommendation and say, don't get vaccinated if you are pregnant. There are no data, only opinions.
Thank you. So, Dr. Porter, this question goes back to this idea of herd immunity. And so the question is, does either vaccine prevent the spread of COVID-19 or just protect the individual who is vaccinated? I heard a young nurse say that she was denied getting the vaccine because she is low risk and assumes it won't help the cause as a whole. So the question is, does the vaccine prevent the spread or just protect the individual?
Yeah, I think we know what we know, right? So we know that people that got the vaccine and not the placebo got COVID less. And we also know that people that got the placebo were the only ones that got a severe case of COVID. So if you put those things together, what we know that the vaccine prevents you from getting severe disease, and we know that it reduces the likelihood of you getting COVID. So the question of, well, what does it do to the viral load? Oh, well, does it still mean that if I cough that I'm going to put out less viral particles? And we don't, those are questions that we don't necessarily have the answers to. So I go back to what I said before about focusing on the things that we know, thinking about the actual risks versus theoretical risks, thinking about the ability for one to lock themselves up, to not be exposed, how well their circle of people, their family and their friends, how serious do they take prevention strategies? You're only as strong as that weakest link, right? So in those cases, I mean, clearly the need for the vaccination is there. Whether or not that answers that question directly, the data that we know is that vaccination is what's going to put you in the best position to not have a severe case of COVID.
And the only thing that I think is important to add to that is that whereas it's absolutely true that that was not studied specifically in the trials, again, based on what we know about other vaccines, the general answer is that the vaccination doesn't prevent only symptomatic infection, but it prevents infection. And so if this vaccine works as effective vaccines that are out there, it will prevent infection and it will reduce transmission. We just don't have the rough data that we need to have to answer the question. But the expectation is that infections will be reduced and transmission will be reduced. We just don't have the numbers yet.
Thank you. Dr. Moreno, this next question is about the vaccine in terms of kind of a basic understanding. And so the question is, do the vaccine components travel systemically throughout the body, or does it stay right at the site of the injection? And that's where the antibodies are formed.
So I will let other experts expand on my initial comments, but the site of entry for the vaccine is a way into the body. The immunological response is systemic, and therefore there will be local reactions which we feel when we are first getting the shot, but the immunological response is systemic. Dr. Benacloche, would you like to expand on that response?
No, I think it's an excellent response. So the vaccine is not given IV, so it's not going to spread on your body as if you gave it intravenously. Essentially, it's going to remain localized in the muscle where it's given. That's the reason you have the local reaction. You can also have lymph nodes in the axilla of the arm where you get the shot. But precisely what travels around is the immune system that is surveilling everywhere all the time. And so you can put the vaccine in one arm, but the effect of the immune response is for the whole body.
Thank you, Dr. Benacloche. The next, and also Dr. Moreno, but Dr. Benacloche, I'm coming back to you because we have several questions about the variant. And so can you help us understand a little bit more about the variant that we're hearing about in Northern California, whether the vaccine will continue to be effective against the variant? Help us understand what all the talk is about.
So all viruses mutate, they change. So when a virus makes copies of itself, every copy may be a little bit different from the other. If for whatever reason a particular copy of the virus turns out to be more efficient in terms of transmission, what you expect is that over time that particular variant will proliferate, will have what you can call a survival advantage, and it will become the predominant variant in a particular region. And so in a way, what is going to allow that to happen is if you end up with a variant that is easier to transmit, that variant seems to have a selective advantage over the other variants, and that variant may impose itself in a viral landscape. In another hypothetical, if you have a variant that kills the host very quickly before it can be transmitted, that variant will disappear because it will be very difficult to transmit. So variants of viruses are going to happen. And the question of whether a vaccine is going to remain effective against one or all of the variants is to be decided. It's unlikely that any single vaccine will be effective against all the possible variants of the virus. And so the answer of the question will take some research. Preliminary studies that have been done in the laboratory, they show that the antibodies that you get when you get the Pfizer vaccine, they inhibit the UK variant in the test tube. So that is the best we know right now. It's better than nothing. So if you had done that experiment and found out that the antibodies that you develop after getting the vaccine don't work against the UK variant, that would be a big deal, but they do work. So we do that is the case in the lab. Whether it is the case in the with people, even if it is or not, we don't know, and we will not know for some time. But that really all that tells us is that we need to keep up the research, and we need to keep up, be ready, find out what is out there, and continue doing the necessary research to be ready for the variations that the virus may bring.
Thank you. Dr. White, there's a question in the chat that says that this person's sister got COVID in March. Should she still get a vaccine?
So so it's a good question. The short answer to that is yes. We are recommending that individuals, even that have had the COVID infection, and thankfully have survived and have recovered. We know that those individuals, for a period of time, do have evidence of antibodies that their immune system, in response to the natural viral infection, have produced. However, we recommend that individuals still get that virus. As Dr. Bunacucci mentioned, the virus induces a stronger immune response than the actual infection does. And we know that those antibodies, what was studied, has been mentioned earlier, provides a good antibody response for about 4 months. So if an individual, the natural infection is suspected to perform in a similar way, so we know that the antibodies potentially don't last forever. So that individual that had infection in March, it would be recommended for them to go ahead and get the vaccine. It would be safe for them to do so.
Thank you. And Dr. Moreno, you started to talk about this in your introduction in regards to mistrust. And so I'd like to hear a little bit more about your perspective, particularly as it surrounds communities of color, as to why mistrust sort of gets perpetuated, why it gets passed along in families or in communities, and what we can do to try to mitigate that.
Yeah, and this is also multifactorial. There's a lot of reasons as to why members of certain groups are often underrepresented in biomedical research. They're also leaving inequities in the access to care and maybe perceived to be less likely to be involved in our clinical trials. Among those, of course, is the trust issue that varies from community to community. We know, of course, the history of practices for research that have been frankly betraying the trust of members of African American community, Latinx community, Native Americans as well, and that have involved their institutions where they comfort care, and also the government organizations that are supposed to address the needs of these communities. There are the issues of trust, but there's also the issues of access. The research is often conducted in specialized centers that do not always provide the care for the underserved communities. We saw an example on the practice here in Arizona for the clinical trials for the vaccines, that sometimes the locations of the research centers were not exactly in the neighborhoods that have the most heavily representation of underrepresented minorities, for example. There were issues with travel, with schedule. There was no information in Spanish in a number of those places. Some of them look pretty fancy and intimidating, so that people from lower socioeconomic status may be a little bit less comfortable in that. And so creating an experience that is really designed to make it so people participate in clinical trials, creating an experience that makes it so people get comfortable accessing care in a place that is affirming, that sort of has your art, that sort of reflects you a little bit, that you have caregivers and providers that sort of resonate with you, that are congruent to the community that we're trying to serve, is also very important. So we have to be thoughtful about those pieces also.
And one thing that I would like to add regarding the mistrust is that sometimes we set ourselves up to disappoint the people that listen to us, and sometimes when we try to be very positive, and we try to emphasize the good things and the things that we know, we are not as humble as we should, or as careful as we should to make clear that there are things that we don't know. And then when something goes wrong, then it's very easy the public to say, oh, these guys don't know what they're talking about. And in the case of the vaccines, it's a very simple example how touted as very safe. They start giving them in the United Kingdom, and the first day there's a very severe reaction that had never been described in the 44,000 people that had participated in the trial. And so that kind of thing really sets yourself up. I mean, you say that that thing is very safe, and then all of a sudden the news show up that some people are having severe reactions and so on. And so it's important that we don't overpromise and underdeliver, and that we are careful qualifying everything that we say and say, this is based on what we know. We don't know everything. There are always things that we're going to learn, and the important thing is to be able to correct course if that is necessary at some point, and engage and try to answer the questions that anybody may have.
Yeah. And that's a very good point. And threading the needle between making sure that we're providing accurate information. So for example, we cannot promise to somebody, this is the safest thing, nobody's going to die from it. But we could say, hey, 44,000 people have received it. And so far, nobody has had this, or only this many have had this. So being factual, I think our community members need for us to translate or interpret a little bit culturally what the findings are. And sometimes the hard numbers do not reflect that. So again, keeping it very honest and very to the point, but helping provide that reassurance to folks that sometimes the hard numbers that we manage among academicians do not always translate to people's understanding and reaction that we're trying to promote.
I agree. And for the first time, we're watching science unfold in front of us. And it's been very public. And so we're all learning. And I think as physicians and scientists, we understand and we're accustomed to hearing about how the clinical trials go, starts and stops and all of that. But I also recognize for folks who may not be as accustomed to hearing all of that information, it can be incredibly off-putting. And so I think that's such an important point that you both raised. So thank you. Dr. Benacloche, this question is for you. If after the second dose, someone hasn't developed lymphadenopathy or a fever or doesn't feel bad, does that mean that they did not get an immune response to the vaccine?
Not as far as we know. So I think that I think the facts speak for themselves. And in this case, what we know is that the efficacy of the vaccines was very high, not 100%, but very high, between the confidence interval between 90% and 98% effective. That's what we know. We don't know that there is a correlation between having a mild reaction or a severe reaction and having a better protection against the virus. We simply don't know. So if you don't have a bad reaction to the virus, a bad reaction to the vaccine, count yourself lucky because other friends and colleagues may have it, and move on. So it's possible, if someone is interested and willing to pay for the test, you can go to your doctor and say, can you please measure the antibodies that are generated by the vaccine to reassure me that I have made them? But we don't know how that correlates with anything, and I think it would be a waste of money outside of a research trial.
Thank you. Dr. Porter, this question is more of a logistical one. Someone here tells us that they're 66 years old. They want to know how much the vaccine costs. Do they need to have proof of insurance? So just a logistics question about the vaccine process.
In the state of Florida, the cost of the vaccine is not to patients. So the state pays for that in Florida. I don't know about other states, I'm sorry, but I know for sure in Florida that nobody has to pay any information. A lot of the testing sites still do request that you bring insurance information, but it's not for billing purposes.
Thank you. Same is true in Arizona. So thank you for that. Very good. I think at this point, thank you so much for all of the questions. There are some specific medical questions that are in the chat. We've done our best to address sort of general topics in terms of, is it safe to get vaccinated if you have HIV, we've talked about if you have a prior diagnosis of cancer, if you've had transplant. There's questions about, is it safe to get vaccine? Maybe Dr. Benacloche, if you can take this one, safe to get it if you've had a prosthetic heart valve.
Yes, as far as we know, it is safe. And there was another question about somebody who was getting too many vaccines, in their opinion. And the recommendation of the CDC is that if it is possible to wait 2 weeks between vaccines, they recommend that. But they say also in the same paragraph that if someone needs the vaccine, you can give it with other vaccines on with less than 2 weeks interval between the COVID vaccine and any other vaccine. So the 2 weeks is preferred just to be able to sort out the side effects of what. But there doesn't seem to be any problem with that. And again, it's very important to know there's nothing alive in the vaccine. Okay, there's no virus in the vaccine. There's nothing that can reproduce in your system and do anything. It's going to be your immune system responding very strongly against a foreign protein.
I'll add that there are no egg products, preservatives, or latex in the vaccine either. I think there were a few questions regarding that.
Yeah.
So I think what I'll do, because I recognize that we all learn from one another when we participate in these panels. So I'd like to go to each panelist. We'll go in the order of which you were introduced, and just allow each panelist to give sort of their final thoughts or their final word. So I'm going to start with you, Dr. Shah Patel, your final thoughts about vaccination, education, and what that means for minority communities.
I do want to touch a little bit on how hospitals and healthcare organizations obtain vaccines, because I think this speaks to the miscommunication and misinformation and the confusion throughout the various states. The hospitals and healthcare agencies and even CVS are obtaining vaccines from the federal government. And every state is distributing these vaccines a little bit differently. So we all, I think the providers who work in healthcare organizations right here and work in the communities are all working to get vaccines to those who need it, but it is all dependent on what your local government has decided. But please know, I know particularly here in Arizona, I can't speak to the other sites, we are working quite closely with the community to see if we can get vaccines outside of our normal organizational structures and perhaps to those areas where people can't drive to, and working with Marion Kelly and community partners to increase access.
Thank you so much, Dr. Shah Patel. Dr. White, I'll turn it to you for your final thoughts and comments.
Sure. Again, thank you so much for the opportunity to join everyone tonight. I think that we've heard loud and clear that the vaccine is safe and that the vaccine is effective, that communities of color were involved in the development of the vaccine. So hopefully individuals can leave tonight with reassurance, knowing that they, when they are available, that they should give strong consideration to vaccinating themselves and their family members. As was just mentioned by Dr. Shah Patel, this is a logistical challenge of distributing and allocating the vaccine to a population the size of ours in the United States. So I encourage people to be patient as local entities are working out the kinks and the logistics of distributing the vaccine. Be assured that it's being done in as equitable a process as possible. A lot of my patients have raised concerns and are getting anxious about when is my turn coming, when am I going to get my email about the vaccine being available. And I encourage them that we are doing our best to distribute it in an equitable fashion according to a specific protocol based upon risk. And in the meantime, to stress the importance of continuing not to let down your guard, of continuing to wear a mask, continuing to socially distance, continuing to wash your hands frequently. The vaccine is wonderful news, but until enough people have been vaccinated and we see a decline in the transmission, we need to continue to be vigilant.
Thank you so much, Dr. White. Dr. Moreno, your final thoughts and comments?
Yes, a couple of important points. I think COVID is a big deal for a lot of different reasons. is really affecting a lot of us in a variety of different ways. It is a time in which we must be intentional and mindful about making sure that we take care of our own wellness. We do not always think about that. And I think an aspect of that wellness is to be generous to others, to take care of others, to be altruistic, and to also be kind. I also, I practice what I preach. So I was one of the subjects in the research trial of Moderna, and I got my vaccine months back. I think I got the placebo. In fact, I know I got the placebo. It was, I didn't feel anything. Now I got the real stuff, so I felt it. I got it through the study, so I'm still participating so that we can all continue to learn. But even though I received it, I was infected on the vaccine, and now I got the first dose at least, and I'm getting the second dose. I'm still doing all the things that I have to do, not only to protect myself, but also to give other people the appearance that I am protecting them as well. It has an impact on others when you show without a mask, or when you invade the 6 feet space that for a lot of people it's really important. So it's part of that sort of social etiquette that we must have with other people, making sure that we continue to take care of ourselves and take care of others, and play kind.
Thank you so much. Cousin, Dr. Porter, your final thoughts?
Thank you. I think the point I want to get across is just that, in my opinion, anyone that can safely receive immunizations should receive the immunizations. I think it's true for the flu. I think it's true for mumps, tetanus, and it's certainly true for a once in a lifetime pandemic that's caused so much damage, so much loss. Be an example. That's why I'm here. Be that example that spreads that around to the people that you care about. Because I get back to my point that we all have this individual responsibility to protect the people around us that we care about.
Thank you so much. And Dr. Banacloche?
Yeah, get the vaccine. It is definitely good for you, and most likely it is good for your country. So just do it.
Thank you. Like Nike says, just do it, huh? Yeah, thank you for that. So for our technicians, I think we have a poll that we wanted to share. These were questions that I believe you were asked as part of your registration, and so I'll turn it over here. A poll should be popping up on your screen right now. The first question we're seeing is, how likely are you to get the COVID-19 vaccine after participating in this webinar? So you click your preferred answer and then hit submit. Was there one more poll question, or do we get to see the results?
Yeah, no, I'll show the results, but only one question.
Ah, thank you. Wow, almost 40% have already received the vaccine. That's pretty incredible. I'm so glad to see that it sounds like we've accomplished what we hoped to, which was to really empower all of us through educating and answering some of these tough questions that have come our way. We hope that you have found this time useful. I know that I learned something from being here with my colleagues and from reading all of your questions. So thank you so much for your participation. I saw that it's been answered in the chat. We will have the recording available, hopefully later this week. Oh, it's almost Friday already, probably next week. But thank you all for your kind attention, for your participation today. And please spread the word. Share what you learned with others tonight, because that's really the way that we're going to make a difference. So thank you so much to all of our panelists. I appreciate all of you for being here, sharing your wisdom and expertise with us tonight. Thank you all, and have a good night.
Thank you.